everyone. Welcome to this first episode of Pathophysiology Stories, a new podcast by Connect. For those of you that still do not know us, we are a newborn association created as an initiative by the former Colonia group. And this was done to foster networking among physiology enthusiasts. With this podcast, we want to rediscover the stories behind how the modern intensive care developed, thanks to the curiosity and passion for understanding the underlying mechanism of diseases. I'm Irene Steinberg, and I'm here today with my colleague, Lorenzo Giosa.
Hello, Irene. Thank you very much. Hello, everyone. And I'm very excited because today we have the honor of hosting Professor Dider Payen here with us from the University of Paris. Professor Payen started his journey as a researcher in intensive care a long time ago as a perfusion expert, and then for some reasons that he will talk us through, moved later on to explore sepsis pathophysiology. Today, Professor Payen will be talking about the energetic crisis in critical illness, a journey from macrohemodynamics to cellular metabolism. Professor Payen, welcome. So, Didier, let's start. Could you let us know how you became an ICU specialist and what was known about this sort of energetic crisis at the time you started?
Many thanks of your group to take the risk to invite a so old guy. And I am very proud because it's related to my friend Luciano Gattinoni, who was the example of questioning why and keeping this curiosity all along his career and refusing the dogma. So saying that, so thank you for inviting me, and I will try to explain how the journey was for me. It's just an example. It's not to reinforce my ego, but it's just to give an example for the younger people who are a little bit lost initially when they have to decide what can I do to be contributive? And just this will be an example for them to know that you will be surely contributive if you have energy, curiosity, and a strong mental for that. So how I became an intensivist, that's a very good question. Thank you, Lorenzo. Honestly, initially, I had no idea about intensive care medicine, but since I had to pay on my own the medical cost for studying in the faculty, I was working as a nurse in the big hospital in Paris, and I remember one night being in a chronic disease floor. We called the so-called intensivist because someone was close to die. And impressively, a young guy came, and this was amazingly efficient. He made some decisions I did not understand, but at the end, after 15 minutes, the patient get better, and the guy was relaxed, giving confidence to everybody, and everybody was feeling this presence as a security for everything. So I said, my goodness, this is a job. I don't know what it is, but I would like to do this kind of job because it's so positive for the people, for the patient, for the team. I want to be something like him. And talking with him after the recovery of the patients, he said to me, I like your questions. I have a lot of questions to ask. And he said to me, tomorrow morning, please, if you agree, we can take a breakfast and you come with me to the place I am opening, a new ICU. And I said, with pleasure. So finishing my duty, I went to this big other hospital in Paris to see the new ICU unit. And I was impressed by the machines, the techniques, the number of nurses, etc. And finally, he decided to enroll me as a member of the team, even I was not qualified for nothing. I was just at the beginning of the story. And he was so kind to spend time explaining me this and the blood pressure, what it is, and so on. So I said, this is a fascinating job. And I spent 3 years continuing my progress as a medical student, working in this ICU and giving me the money enough to stop all other job I was obliged to do. And I said, for sure, if I can succeed the exam, I will be an intensivist. And I was successful for the concourse to be a medical doctor and to get a specialty. And I decided to become an intensivist.
Well, thank you very much, Didier. This is really interesting, so far you've talked us through how you became a doctor and how you were excited and interested by the ICU world. But eventually, why did you decide to also move to the research field? What was your initial interest in terms of research topics, and were there any main gaps of knowledge that you were aiming to fill by then?
Yes, when you are starting a new specialty, so you cannot see what is missing for you because all is missed. So finally, you spend your time to learn the clinic to avoid any mistakes and not missing something that you should do. And spending one semester and then a second one and then third one and changing the specialty of intensive care, more devoted to the liver or more devoted to the kidney or more devoted to the lung, I realized that intensive care medicine needs a lot of clinical competence to analyze and to do the triage and to make a strategy to use the supportive techniques. But at the end of the day, I realized too that probably most of the patients who had to survive will do. The most severe patients who had to die rapidly will do. And we have a third of these patients for whom the quality of your understanding may change totally the course. And with the clinical knowledge I tried to get the best as I could, I realized that even I do my best, some people continue to die, some people survive. And I said, maybe we do well what we know, but we don't understand exactly why we don't do this or we do that. And I would like to better explain the decision we make for the therapies at least. And at this time, all the energy was spent to use the adequate supportive therapy in terms of ventilation and cardiovascular treatment for shock. And if you do well these two things, and then sometimes you started to use the renal replacement therapy, which was not born at this time yet, or at least in the ICU, the hemofiltration, for example. So it was really well if you do no mistake. Based on that, you give the right for God or the fortune to decide if the patient will go well or not. And I was a bit frustrated because sometimes I understood what happened, but most of the time I didn't. The people get better or worse, but it was not so clear why. I decided to try to learn some more deeper concept and what means circulation, because at this time the shock was leading the cause of death with the respiratory failure, but the hypoxic end of life was not so frequent. So most of the time the people were dying because of hemodynamic shock, I would say. And I decided to first perhaps try to understand better the circulation in itself.
Well, that's great. That's really interesting. So, just in order for me as well to understand, because going through the immensely vast literature that you contributed to, it seemed like in the beginning you were very much focused on how the arterial side of the circulation works, and in trying to understand what are the forces that govern the arterial side of the circulation. Is that correct?
Absolutely. I was listening my mentors, and the circulation seemed to be the most important factor. And looking at the circulation system, the arterial side or the left side seemed to be the predominant one. The people were interested to maintain the blood pressure. Then, of course, you need to do that, a good pump, a left cardiac pump, and adequate resistances to afford this blood pressure sufficiently good enough to maintain the perfusion to the tissues. That was the deal that we have to achieve when we have to treat a patient in a life-threatening situation. But, you know, giving fluid, giving presses, giving sedative drugs, giving all these things which were supposed to interact together, sometimes you succeed, sometimes you did not, and it was not so easy. And I realized slowly but surely that maybe the hemodynamic resuscitation is not so simple than to give fluid or to give presses. And then I tried to understand better the left side and the right side of the circulation.
That makes perfect sense. But I know that at the time, you sort of felt that what you were looking at in terms of pressure were not enough to explain to you what was going on in this arterial side, and you started focusing on things that measure flow, Doppler. Is that correct? Could you talk us through that a little bit?
Yeah, absolutely right again. The question was, and maybe remains a good question, is it better to base the resuscitation for the patient on the blood pressure level? Or is it better to keep the blood pressure as it is if you are able to maintain the blood flow and the blood supply to the tissue? The pressure is less important. So finally, I got at this time examples which were extremes to understand this. If you clamp in the animal model the aortic vessel, you get the best pressure you never had, but only for 1 or 2 beats. So finally, the pressure in itself cannot be a goal. At the same time, I learned at this time, I was not an anesthesiologist yet, but I heard that some anesthetists were doing the so-called deliberate hypotension for the subarachnoid hemorrhage neurosurgery. And I was interested to see what means deliberate hypotension. And they were using sodium nitroprusside to decrease the blood pressure around 35, 40 millimeters of mercury. So at this time, I was impressed, because if the pressure is the goal, why can you do this and apparently safely for the patient? You perfuse, but with a very low pressure. So finally, perfusion and pressure are not so easily linked, and I have to understand that. So the reason why I keep, of course, the knowledge for the left, but I was convinced that it was more important to get a flow, and then to get a flow, how the flow is regulated. And then I discovered a famous name that everybody knows, but it was my book for the day-to-day lecture. And Mr. Arthur C. Guyton was publishing this fantastic book, which disappeared now for the library, which is named Cardiac Output and Its Regulation. And with this book, I understood for the first time that the heart is absolutely crucial, of course. But going back to the very old articles from Starling, Mr. Starling, I understood that the so-called preload means a right side of the circulation. And Mr. Guyton explained that the amount of blood coming back to the heart is the limiting factor for pumping, if the heart is pumping adequately. In other words, you can get a low flow or high flow depending on the venous return you have, admitting that the venous return is finally equal to the cardiac output, because it's the main determinant. So then I said, oh my goodness, that makes sense. And I have to understand what are the determinants of this venous return. And it became quite complex, to be honest, to understand the circulation in the venous side. Finally, I got a chance to move at the same time on a research lab of hemodynamic oriented for blood pressure or hypertensive disease, and Professor Michel Safar in Paris. And I started to learn hemodynamic, but in a different way. They were more interested in the periphery than in the heart itself. And looking at this, I learned the concept for venous return from Mr. Guyton. What are the determinants of this? And I discovered that the nitrates that everybody was using for coronary patients was in fact very efficient to reduce the pain during the cardiac crisis or the coronary crisis, because not the dilatation of the arterial vessels or the coronary vessels, which are by essence with a limited flow and stenosis, but because it was limited tension on the LV and the RV. And this tension is limited because the nitrates were essentially efficient on the vein, becoming more supple, having a more compliance, storing more blood, and having a lower pressure in the venous side, then lower pressure in the ventricles during diastole. Understanding this was a big advance for me. I decided to play with the volume, the compliance, and I understood that the epinephrine or norepinephrine may change the elasticity of these venous vessels. And then with the same amount of blood in the vessels, you can shift the blood to the heart, or you can store the blood to the periphery, depending on the vasometricity of the vein. And this concept has not received a lot of attention in intensive care medicine field, but was very popular in hypertensive disease and cardiovascular globally. So I moved to this and tried to reduce and to play with the venous return more physiologically than giving drugs. And this was interesting because when you look at this time, what happens in the literature, I was impressed by the books which were published by the NASA physiologists, and they were interested to understand what is the behavior of the cardiovascular system when you are in a microgravitation as you live in the arrow in the space. And with no gravitation, what happens for the venous return? What happens for the cardiovascular adaptation? But I read this with passion. And finally, I found that there is another point which is very well known by everybody in the military field, is how to pilot a jet and then being submitted to very important microgravitation plus or minus 5, 6, 7 G. And then with this, sometimes the pilot is losing the consciousness and is losing the plane and may die from. And again, it was related to the storing of the too much blood coming to the heart and to the brain. And finally, and they developed the so-called inflated G-suit to compensate the gravitation created by the flight conditions. So I said I should perhaps use this G-suit they have for pilots, for the patients with mechanical ventilation or having some abnormal venous return, and maybe I can change the venous return mechanically without drugs, without volume. And then we did the first experiments with this after buying a black G-suit. It was very impressive in the ICU, but non-invasive. And with this, we were able to correct perfectly the hemodynamic modifications induced by mechanical ventilation without giving any milliliter of fluid or drugs. And I discovered the reality of what I learned before. Venous side is a key issue for hemodynamic stability in ICU.
Okay, that is definitely not something that you see every day. So you started your journey in research looking at macrohemodynamics from the arterial side. Then, as you were telling us, you started to understand the importances also of the venous system. But later on, you moved to investigate also the mechanism of functioning of the right ventricle and pulmonary circulation. Is that correct?
If I try to understand the following this, you move the blood from the periphery to the central compartment. What means central compartment? It means a right ventricle and pulmonary circulation, and then left ventricle. And I was interested to understand what means the right ventricle function. It is well known for the left, but not so well developed at this time for the right. And very important groups all over the world were moving to better understand what happens in critical care medicine when the right side ventricle is not working well, and what means not really working well. And I discovered this concept, beautiful concept of right ventricle as a gun. So you get some blood coming inside a chamber and then closing the doors of this chamber and compressing the chamber in a second chamber and then pushing the blood to the pulmonary circulation. And this was really amazing to see how this pulmonary blood flow might be essential, because otherwise you don't get the left ventricular blood flow. And this regulation was so subtle to be adapted with a relatively low resistance circulation, the pulmonary circulation. I was impressed to see that we were ventilating the patients and pushing from negative pressure to positive pressure, sometimes high positive pressure at this time. And then this was, of course, creating some high resistances to flow, and the right ventricle became really in difficulty because never been trained before to force against high resistances. And then I understand how we can help the right ventricle, or at least how we can prevent to put the right ventricle in difficulty, understanding what does it mean in the pulmonary embolism, etc. Then we move to the lung. Of course, the flow goes through the lung, and I learned at this time, and being in contact with Luciano Gattinoni, developing the concept of low VAQ ratios. In other words, the oxygenation of the blood at the end of the lung was the result of the amount of blood circulating, for sure, but this amount of blood has to be oxygenated adequately. And then there is an adequate ratio between oxygenation and flow in good area of the lung. If you have more blood going to the place where the lung is obstructed and not exchanging the oxygen, then you have a lot of blood which is not oxygenated coming back from the lung. Then you get a shunt. And I discovered the shunt again. With the flow, you can change largely the amount of the shunt. If you reduce the blood flow, if you increase the blood flow, if you give us a matter of drugs, etc. So this was a long time of experimentations in human beings and animal models to understand how can we improve the oxygenation coming out of the lung. Then I moved to the left side, but the left side was very well developed, and many groups were taking care of the left ventricular function, taking care about the aortic blood flow. And I was just thinking about the pulse ductility, and the pulse ductility is essential to push the blood, not only by the ejection of the LV, but also to push the blood along the arterial trees to the tissues. And this elasticity of the large arterial vessels is essential for this pulsatility, maintenance, efficiency for perfusion. So that was globally the way I was obliged to go through, being logical and based on physiology.
Thank you, Professor. So, if I understand correctly, so you started to look at the arterial side, And in order to understand how the arterial side worked, you had to look also at the venous side. You had to look also at the pulmonary circulation. But putting all these aspects of macrohemodynamic, if we want, together, that was still not enough to actually have an impact on patient outcome, or at least not the impact that you wanted to have. So after a while, you decided to move and look also at the microcirculation. That's correct?
You're absolutely correct. It was totally unknown for me after 10 years in the ICU, developing this kind of macrocirculation issues. I was just aware about the existence of the microvessels, but a part of this, I had no clue. And at this time, nobody was looking really seriously to the microvessels in critical care situation. I discovered that maybe some basic scientists were able to do very nice measurements with parameters which were totally different than the one we use for the macrovessels. And I tried to understand what kind of methods could be potentially applicable for the patients and human beings, because I was convinced that the place of the microcirculation, the level of the microcirculation, was probably the place where we had the most important interaction between the blood and the content of the blood and maybe inflammatory mediators or inflammation and the tissue itself. So it is the place for the actions. So finally, having a flow or low flow or no flow may probably totally change the tissue wellness and the disease. Then I look at the techniques and I found that the laser Doppler was used for many years by many scientists. So I decided to buy one. And using this laser Doppler, we were measuring the very superficial cutaneous laser blood flow, which is really, really regional, and discovering step by step that we can look at the microcirculation by different ways. Finally, looking at the metabolism at the microcirculation level, measuring, for example, the tissue saturation of oxygen with the STO2 machine, and also imaging the microvessels in sublingually developed by Professor Gianninci, and we collaborated a lot on this to image the circulation of the microvessels to show that it's normal, or at least when it is abnormal. And we found that the so-called distributive septic shock had a real imaging translation seen on the micro camera he was able to develop. Then based on that, the concept came from some other teams that there is an abnormal microcirculation. Even you do your best to maintain the big circulation well, even in this well condition, the microcirculation might be very sick. So the concept of conformity or heterogeneity of the response of the microcirculation came. It could be the consequence of the big circulation abnormalities, but it could be also a local disease, a microvessel disease, even you have a normal microcirculation. Then I understand that moving closer to the tissue, we have to go to the tissue. We have to go maybe to the cells, and maybe to the cells from the blood, to the cells from the tissue, to better understand what's going on. It's not simply hemodynamic failure.
Perfect. Well, Didier, thank you very much. This is puzzling somehow, isn't it? Because it looks like when you were thinking at the energetic crisis in the beginning, you and your colleagues back in the day, the initial idea was that the main problem was in the macro circulation, because this is what you could see and what you could measure. And the idea was that, well, by fixing the macro circulation, I will also fix the micro circulation in a way. And then you switched to the thought and to the finding that actually this is not always the case. We know that there are some relationships, and you will correct me if I'm wrong, but for example, we see it with fluids. If we give fluids, we do something to the macro circulation, but fluids also impact on the micro circulation by vasodilating on their own. But there's not always this clear relationship between the big arteries and the microcirculation. And so you started sort of thinking that if the cause of the peripheral problem is not in the big arteries, there might be something that is actually causing the problems in the microcirculation. And so you switched to, because by looking at your literature, there is a big switch into all that is immune dysregulation, inflammation. Is that right? Was this the reason why you went into this topic, to sort of explain to yourself why you had this dissociation between the big and the small circulation?
Absolutely, it's because I was disappointed, to be honest. I mean, I was thinking it was more simple to get a solution, but finally the solution is not simple, and the conflict is located at the microcirculation level. The conflict between the circulating cells and the endothelial cells and the tissue cells, and then I had to understand what means inflammation. And I had no clue about that. I was talking about inflammation all the time, but a part of the name, the word inflammation, I had no clue. I decided to learn this and went to become a student at the Pasteur Institute and learning with Jean-Marc Cavaillon, a big specialist on that. What means inflammation and immunity for infectious disease or other way to get an inflammation, and discover the word, which is extremely complex. And I'm spending hours, months, and years to learn this. I decided to move to the inflammation and to keep the hemodynamic parameters to show that something is abnormal, but to add this on potential explanation of the conflict and the abnormal microcirculation. And then we started to develop with the team. The team became exhausted because of too fast and too many ideas coming, but they were passionate. So we did measurements for cells function with the flow cytometer. We learned the cytokines and what means the measurements and the ELISA techniques. So we did ourselves the measurements in our lab day to day, no congelation. So we did a fresh measurements anytime, night and day, and including the weekend. And we got a very fascinating results. And finally, we moved to the cells, the immune cells, and we moved to the genes to understand if we have susceptibility. In other words, is there any sequences on our genes which may favor the occurrence of the severe infection consequences or not, like in the cancer. And we found 17 genes associated with a high susceptibility to die. And finally, okay, you are constitutively susceptible or not. And then when you have these genes concerned, what happens for the expression of the genes? So are you doing a lot of mRNA or messenger RNA? And we started to measure the mRNA. So in the group, it was always a stimulation to get a new technique, new technology, or new learning. And we published in 2007 the first paper on this mRNA expression on circulating cells in human beings having a septic shock, showing the relationship with, for example, acute kidney injury. It was fascinating. It's still fascinating. And now we understand that this potential omics technique are really essential for characterizing better the immune status, the inflammatory status, and perhaps to adapt the adjuvant therapy for septic shock patients to try to reduce the mortality. It's a challenge because all the inflammatory molecules tested in more than 70 trials, almost all of them were negative. So finally, the question might be, is it the good approach to try to get a solution for this huge inflammation, even we don't know very well what means huge inflammation in sepsis.
Well, if we talk about immune system dysregulation and inflammation, is a bit difficult to do so without mentioning the COVID-19 pandemic, because of course that I think that had a huge impact. So can you please share maybe what that brought in terms of research in this field?
Yeah, thank you for this, because it was, as for everybody in the world, patients and doctors, a dramatic moment. And in Italy better than anywhere else. It was amazing to see how a viral infection is able to create a big lung distress syndrome. And Luciano was contributing again a lot to understand better what happens in terms of description of the acute lung injury. But still, the molecular level of mechanistic way this SARS-CoV-2 is able to destroy the lung by the lung cells itself, but also by the immune cells, which are trapped in the lung, is a real issue. And we applied to the COVID patients the knowledge we got from previous data on ARDS patients. Having said that, so we applied this for reduce the heterogeneity, as Luciano mentioned many times, for the ventilation. But unfortunately, the patient continues to die because it's still under investigation to understand what really happened to destroy the cells in the lung, and maybe not only in the lung, seeing now the long COVID becoming a real healthcare problem all over the world. So virus infection and consequences remains a very big problem. But I don't think it is like a sepsis by itself. It's largely different and maybe more complex than the bacterial sepsis that we know.
Thank you, Didier. Thank you very much. So just to go back for me and for our audience to what you were referring to earlier on, speaking about inflammation and immune cells, because this must have been a great change in paradigm in looking at our energetic crisis, in the sense that, if I understand correctly, the initial idea was that everything was happening at the level of the vessels, big vessels first, small vessels later. Maybe the initial idea was that the bacteria or the viruses or whatever was causing this severe infection was on its own causing this dysregulation in big and small circulation. But then when you move to inflammation and you realize that there is something that is activating this inflammation, and you look at the immune cells that are participating in this, the story gets very difficult, doesn't it? Because it seems like our energetic crisis is actually happening inside our immune cells, isn't it? And so I've seen that you've also started publishing and studying about what happens to the gene expression inside the immune cells. How do they respond to the bacteria, to the viruses, and how they can switch their internal gene expression and metabolism to sort of cope with this internal energetic crisis. Is this correct?
Yeah, you are absolutely right, and this is important to realize that describing a complex system which is there for protecting ourselves against the attacks from foreigners, including the infective agents, but not only the cancer cells too. And having a cancer myself, so I opened the mind more wisely to all the mechanisms by which immune cells are reacting adequately or not adequately. And I was surprised to see that if the system is so redundant with a lot of pathways, communications, and redundant mechanism, it's difficult to imagine that with one molecule even a very good one, proven the basic science experiments, it is difficult to imagine that with one monoclonal antibody or whatever, you can change the course of the immune response if the immune response is killing the cells and the tissues. So fortunately, I would say, it is more complex than this. So one molecule to improve all this very, very sophisticated machinery acquired in a millennium of years, it's really, for me, naive. But there is perhaps, I'm not sure yet, but there is perhaps another way. If you consider all the cells is doing, reacting against something, this hyperactivity of immune cells has, for sure, an energetic cost. And the cost of energy to have an adapted immune response is fascinating. Is this well known? And looking around, I was talking with immunologists, and they were not really interested to understand where the energy to do the immune response came from. And it's only because reading the oncology literature, I was impressed that to see that the oncologists have different way of thinking, and they propose to control the tumor growth by specific regime, which was essentially a regime without glucose and moving to the ketone bodies and blocking the glycolysis. And the glycolysis, I discovered this as called as the Warburg effect, the name of Mr. Otto von Warburg, and in 1926 describing that the cancer cells were able to consume 400 more molecules of glucose than the regular cells, 400 more. If you cut the supply of glucose to these cells, the cancer cells are dying. And this was kept silent until the 70s, and starting again to be perhaps a way to control the function of the cells, cancer cells, but immune cells. And then many papers in the 90s and 2010 were starting to demonstrate the role of the energy coming from the glycolysis, aerobic glycolysis, when the immune cells are activated. And finally, each time a stress cell, like immune cells, but not only the immune cells, each time you need more energy to do the job, their specific job, you need more, and the more is coming from another way than the mitochondria itself. And the other way to get more energy, useful rapidly, is the glycolysis. Then perhaps with this, we have some relationship between the metabolic shift, as I described, related to the immune phenotype of the cells. And this is the beauty of the last 5-6 years, to show that when you are changing the phenotype, immune phenotype of the cells, you are looking for the metabolic status of these cells, and they are shifting totally their metabolisms from status quiescent to a profile which is called a resistance, and then they fight against antigens, and then rapidly this is regulated to move to the tolerance phase, during which the metabolic is shifting again. And this is perhaps a target for new treatment to modulate, not to block, but to modulate the immune response when it's not tolerated by the patient.
Thank you, Professor. So I guess in 50 years, you had the time to do research in a very broad way, and you had the chance to explore what I would say are different aspects of the same issue. So if I ask you to explain to a medical student or a young resident what sepsis is, what would you tell me?
That's a very difficult question, but I will try to answer a bit this. If I am a young student now, but full of energy, full of passion for medicine, full of curiosity to understand with a strong and solid mental to love the continuous effort, I will start to work on sepsis, because sepsis is not only a chapter of critical care medicine, it's a worldwide issue. It is the leading cause of death if you put the bacteria, the virus, and the parasite together. This is far away the most important death we can have, and this is crucial to try to improve the outcome of this patient. So I would say the topic in sepsis is a good one. To be sure that you are sufficiently rapidly aware to become your own way, you should know very well the sufficient knowledge, not too much, sufficient knowledge on bacterial, viral, and parasites, and how they are dangerous, what are the antigens which are creating the immune response, and how to treat this, and having some pharmacological ideas, so-called PK/PD, and how the supportive therapy you use, hemofiltration, whatever, is able to change the drug disponibility. The first step is to learn this. The second one is to learn sufficiently the name of the players in the immune system and inflammatory response, like you know the name of the Squadra Azzurra for the soccer, and I think it's important to know the name and how these players are playing together, not to be a specialist of the football and then immunity, but to understand how does it work and knowing the words and what is behind the words. And the last but not the least is to help by all the ways you can, all the initiatives trying to develop the biomarkers to characterize the patients, the immunity, the susceptibility, the sensitivity to the drug, etc. So this is absolutely essential, and we missed yet good biomarkers. Good biomarkers means easy to get in a relatively short time response for a reasonable cost and specific. So the challenge is big, but without biomarkers, it will be very difficult to improve the quality of care. And finally, understanding this sequence of inflammation and association with the metabolism, you can perhaps avoid any mistakes. For example, giving a lot of nutrition at the beginning of the acute phase is a nonsense. The more you give calories, especially glucose, the more you will kill the patient. And in the future, it will be very essential for the young guys having this understanding overview of inflammation and metabolism. It could be essential for them to try to learn how the learning machine or artificial intelligence may help to put the data from the patients you can collect into the machine and see how we can get some individualization of the therapy. And that's the way probably they will succeed very well.
Didier, thank you very much. I would continue listening to you for hours, obviously, but we need to come to a sort of conclusion. But I would really like to ask you, because since you talk us through this very nice and incredible research journey, on the one hand, if you have any specific suggestions to students or residents that nowadays are interested in research and that find themselves facing more and more hurdles from several perspectives. And on the other hand, for the more general audience that is even not so much interested in this topic, is there any specific readings that you would recommend? Would that be a book or a specific paper that you would really suggest that our audience should keep in mind?
Absolutely. For the first question, I would say, I love sports, and I was a sportman, and the competition was really motivating for me. And to be good in the competition, you have to get the mentality to never give up. And honestly, never give up is a quality, in addition to the curiosity, which is absolutely essential to become a great intensivist. The second point is you cannot do anything if you don't have the culture. And the culture has to be in your mind, not in your phone, in your left buttock. You have to read, you have to memorize, you have to write, and ChatGPT can do that for you. But if it does for you, it is not in your brain. And missing it in your brain is a big mistake. So you have to learn. And if you are passionate enough, working all the time you can, not becoming crazy for that, but still quite motivated, you are becoming a champion, and then you will be very useful for the patients and the young students.
Thank you again, Professor, and thank you also, Lorenzo. So I think we have come to the end of our story, and I would like really much to thank you both for this really nice discussion. Also, I would like to invite all our listeners to follow the Connect page on the social media. We have Instagram, LinkedIn, and Facebook to get updates on all the activity that Connect is starting to do. So, Pathophysiology Stories will be back soon with a new episode. And in the meantime, I thank you for listening. Goodbye.